Good morning, everybody. Again, a great pleasure to be here. I'll use the microphone in just a second. I'm going to do I'm going to speak in English again. No time to learn Japanese overnight. So I will just start with one question. Who of you was at the session, at the meeting, at the conference yesterday? Almost everybody? Not everybody quite, okay, but almost everybody. That's good, thank you. So what we thought is, rather than, because almost everybody, I think it was about 90% of you saying that they were at the meeting yesterday, rather than repeating what I said yesterday, we thought that we would make most use of the time by speaking to you about how to use the evidence to decision frameworks in a way that they become efficient for you and that they help you with achieve your task in a small group. And the purpose of this presentation is to speak about why we rarely need formal consensus methods that many of you may have been exposed to when you use the evidence to decision frameworks. And just to start, I think this is not working right now, but that doesn't matter. I will stand here. So just to start, these are my disclosures here. I don't have any financial conflict of interest to actually disclose. So let me just see here. Yeah, it's not, I don't think it's going to work. Can you just see if it's going to work again? Should be good in a second. I'll start like this, and then we'll see if we can get it fixed. But so these are my disclosures. Don't have any financial conflicts of interest here to disclose. I work with a number of organizations. I mentioned that yesterday, same conflict. But I wanted to start with just one general point. There is confusion, lots of confusion, between what is, thank you. Yeah, that works now. Thanks so much. So confusion between what is evidence and what is opinion. And reducing that confusion reduces the need for formal consensus methods, we believe. So I wanted to introduce a concept to you that is quite relevant for many decision-making situations, and that is the concept of expert evidence. Okay, expert evidence are essentially observations or experience that is obtained from a person who is knowledgeable about or skillful in a particular area. And this could be a patient, okay? A patient who has experienced a condition, in particular a rare condition, will have more experience about that disease than most doctors when it comes to how important the outcomes are, for instance. And then the second point is that expert opinion is actually a judgment based on evidence, based on an interpretation of evidence. So in other words, an opinion by an expert can be informed by having seen a few patients with a disease, or it can be based on an interpretation of many randomized controlled trials. Okay, an expert expresses an opinion on the basis of evidence. That evidence may be a few cases, or it may be 20 randomized controlled trials. So when you hear people talk about expert opinion and expert opinion-based guidelines, it makes no sense. Right? Because guidelines should always be based on evidence. That evidence may be very few cases, or it may be lots of randomized controlled trials, and experts are there to interpret them. So there is something that is very helpful for most participants in guideline panels to understand, and it empowers them. It's very important for the tutors, and that is this piece. It talks about distinguishing opinion from evidence in guidelines. And there's essentially 4 things that we emphasize that are listed there. Sorry, the screen is a little small, but the first is that we should be distinguishing expert opinion from expert evidence. So what experts bring to a panel. We should be introducing expert evidence always at the right time. We should consider conflicts of interest by experts in an appropriate way. And then we should appraise any evidence that experts bring to a table in the same way that we evaluate randomized trials or observational studies. That's the first point. Okay, the next point that I wanted to make is from an example. So I'm going to show you a few examples for how evidence-to-decision frameworks have been used in the past. Because you will hear a lot about these evidence-to-decision frameworks, which are the backbone of GRADE. This is from a guideline, is one of my most cited guidelines. It's been cited like 5,000 times. The idiopathic pulmonary fibrosis guidelines, or 4,000 times, not exactly sure, together, including the updates. And I wanted to show you a little bit in terms of how we can work with experts who may even be conflicted in a very constructive way. So typically, you probably are aware of it, and yesterday it was mentioned, there is a misunderstanding in the era of evidence-based guidelines that recommendations are developed by clinical experts in the field, and that this may be different, so evidence-based guidelines, from consensus-based guidelines. My plea to you and my attempt to explain the difference is the following, that any guideline, even if you use even if you use evidence from randomized controlled trials, will require consensus, because how else are you going to move forward, right? So if a group of people like you, panel members, many of you experts, sit together and you look at evidence, high quality evidence, low quality evidence, in order to arrive at a recommendation, you need to achieve consensus, okay? So if you use evidence or not, consensus is required in order to make a recommendation. Therefore, a distinction between expert consensus-based guidelines and evidence-based guidelines is not necessary and is actually wrong, right? So the point being that consensus-based guidelines should be, the term should be scratched from our epidemiological lexicon, okay? So consensus-based guidelines, it's not a good term. It doesn't, is not sensible. Okay, so in other words, whatever evidence you use, coming back to the expert evidence, consensus is required. Recommendations should be based on evidence. Therefore, you should only develop evidence-based guidelines. And I think many groups will stop using the term consensus-based guidelines because consensus is always required. And voting is just a form of achieving consensus. Okay, and then I'll go to the evidence-to-decision frameworks, criteria in GRADE here. So you've seen some of this. So as you look at the slides, so these are different slides, right? The slides that I have there to not show you the same as yesterday. These are different slides. So these are the evidence-to-decision frameworks as they have been introduced to you yesterday. They include a question, which you will go through, and it was already introduced. You're talking about acute appendicitis today. That's the population. The intervention is surgery. The comparator is antibiotics. The outcomes are mortality, having complications, having surgery, and so on down the line. There's a section on background and conflicts of interest. You already have experienced that yesterday. Then there's this assessment that I'm talking about, that I talked about yesterday, conclusions in the form of a recommendation, and then you present that information. And the evidence-to-decision frameworks, as a very brief recap, can be utilized to take different perspectives and make different types of decisions. And they also facilitate the group decision-making process, and I'll get back to that as it relates to consensus. And the whole process, these criteria, I mentioned that yesterday, I explained that yesterday. is based on an appraisal of research evidence and judgments. And also, just as a recap, I showed you these individual judgments yesterday, and you will go through that today. The individual criteria include, for instance, a judgment by you as a panel on the desirable effects of an intervention. And I mentioned to you that this is typically based on a very detailed assessment of the evidence, which you will see in the form of a summary of findings table. Okay, so how do the evidence to decision frameworks help you with making decisions in a transparent way and allow you, for instance, to involve people who may have even severe conflicts of interest? This is how we do this. So there is some, obviously, the section on research evidence in the evidence to decision frameworks, which we explained yesterday and talked about. There is a section on additional considerations. This is typically what a panel adds during a conversation, during a discussion. And the people even with conflicts of interest can provide information about the research evidence and additional considerations that may be relevant. This is being discussed. Then it comes to a judgment on an individual criterion. So for instance, a judgment by a panel to say that surgical appendectomy is much better in terms of desirable effects than antibiotics, and you may say there is large desirable effects. That's the judgment. That judgment is typically made by people who don't have conflicts of interest. They can participate in everything else, but not in the actual judgment about how large the effects are, and so on. Anything that determines the direction and strength of a recommendation should not be influenced by people who have been deemed to have important conflicts of interest. Okay, so, and we showed you yesterday, at the end of the day, you arrive at a point where you have worked through the evidence to decision frameworks as a panel and made judgments on individual criteria. These individual criteria then are recorded and allow you to make a recommendation, as you will learn today. I mentioned this paper yesterday. I really recommend that you take a look at this, even as a panel member, but particularly for the tutors, obviously. But what these judgments that you have then made, I give you a different example, that you have then made help you with is the following. That whenever you have a record of what was determined, for instance, about the desirable effects, or let me use this here, for instance, about the desirable effects, we'll be there eventually. Ooh. Okay, there we go. Okay, there is the pointer. So for instance, once you've made certain decisions, such as that there's very low quality of evidence, that there's a lot of variability around values and preferences, and that you're not exactly sure if the benefits are greater than the harms. When these type of things happen and you've gone through that in individual steps through the judgment on an ETD, it basically makes it very clear that panels cannot make strong recommendations either for or against, this thing is not working, either for or against the intervention. Let me use the mouse perhaps. That's the easiest. So that you cannot make strong recommendations for or against the intervention because there's a lot of uncertainty that comes out in the judgments about the individual criteria. So the evidence to decision frameworks here help you to bring panels together and say, look, we know that there's very low quality evidence. We know that it's not clear if there's more benefits than harms. You shouldn't make a strong recommendation, which is another thing that helps, what the ETD frameworks help with. So to make sure panels don't make unreasonable decisions. So very quick example for how this, if you have a situation like this, where the balance is not clear, you typically should make a conditional recommendation, and that would be framed by a guideline panel, indeed, with underlining the conditional recommendation and the very low confidence in the estimate of the effect. I'll give you another example. I'm going back to the example about idiopathic pulmonary fibrosis, where we laid out the difference between expert opinion and evidence. So again, this was a panel with 17 panel members. I mentioned to you how we go about developing a recommendation. Everybody on the panel was allowed to discuss and add information. Those who had a conflict of interest were not part of the actual judgment process. And here is just a brief explanation. So there were 8 pulmonologists who had conflicts of interest, but obviously when you develop a guideline, you want the right people to participate in that guideline. So these 8 pulmonologists with conflicts of interest, because they had been conducting trials and so on, participated. And they were allowed to stay in the room during the discussion, but they were not allowed to participate, as I already said. They were not allowed to participate in the actual judgments. So the remaining 9 non-conflicted members were then informed by these pulmonologists, but they made the judgments and the recommendations by themselves. Okay? And interestingly enough, when we later asked the conflicted members, those with strong opinions, out of the 20 or so recommendations that we developed, only 1 single member felt that for 1 single recommendation, they would have made a different recommendation. This is a quite interesting observation, right? That the participation at the end of the day probably leads to a degree of, agreement between conflicted and non-conflicted members that, you probably, by excluding them, make the right decisions, right? That's one way of interpreting them. Okay, and interestingly enough, the editor of the journal actually was part of he observed the process, and he then wrote a little editorial saying about this, that the conflicted and non-conflicted members participated together. It seemed to me that that process really, really worked very well. Okay, I will use one other example for you. This is from the European Breast Cancer Guidelines that I introduced yesterday. And again, you make judgments on the evidence to decision criteria. And when we do that, for individual judgments, we still feel that in many situations, people with strong opinions can influence the recommendations. So we suggest that even for individual judgments, individual criteria, when there's voting required, that we make this voting anonymous. And what we do is, when it actually comes to voting on individual criteria, so for instance, whether or not the benefits outweigh the harms, we note oftentimes that either the results of the voting, or we just say, if you ask people to agree on something, we just label how many people disagreed with an actual judgment, okay? So that's what these additional considerations are for. Therefore, this is for transparent recording. Then finally, when it comes to voting on a recommendation, I just wanted to highlight this particular point. So for sometimes for strong recommendations, not everybody will agree. We have our record of what happened, and then in the actual justification, we might say, voting among the panel members without conflict of interest resulted in the following. 15 members voted in favor of a strong recommendation, 2 members voted in favor of a conditional recommendation, and 1 member abstained. Okay? So we record all of that in our evidence to decision frameworks. And then finally, what the evidence to decision frameworks also help with is that they make unreasonable judgments unlikely. They make them almost impossible. So for instance, if the benefits are small, an expert cannot argue that the benefits are large, because it is so obvious by looking at the individual criteria that they are less likely to influence that process. So for instance, here as an example, if you have very small differences between an intervention and the comparison, so for instance, in your example, if you had only one minor complication more out of 1,000 people, people couldn't say that this is a large difference. It doesn't make any sense, right? And this is a result of disaggregating judgments on the evidence to decision frameworks, going from the desirable effects to the undesirable effects. Expert coming to the table wanting an intervention, by disaggregating the judgments, separating them out, you make it less likely that people can influence the actual recommendation. Okay, so in other words, what happens is these evidence to decision frameworks keep panels honest. So for instance, when side effects are large, okay, because it is frequent and happens frequently, the panel cannot say, oh, there are no side effects, because it comes out of the numbers and it comes out of the separate judgment about the undesirable effects. Okay, so in other words, what I'm trying to say is one other example. This is for the tutors primarily, as you're taking the group through your judgments. It's actually the research evidence that leads to consensus. And often you don't need lengthy processes, as opposed to just any method that you are utilizing. And when you, for instance, use voting, I mentioned that in our pre-voting session, so you can use voting with the panel member, with the panel members before you have actually a meeting. And if these votes indicate that for a certain criterion, for instance, desirable effects, there is a lot of disagreement. One panel member saying large, this is from an autism guideline, for saying that is, or for saying it's trivial, you know that you will have to spend some time with the panel on discussing this particular criterion, because there is disagreement and you need to sort out where the disagreement is coming from. Okay, so this is really all about evidence to decision frameworks. You will hear later in the presentation about when it is reasonable to make a strong recommendation when the evidence is of low quality, but that also is a result of using the evidence to decision frameworks. You realize there's low quality, we shouldn't make a strong recommendation unless there is an exception that applies. So in summary, the evidence to decision frameworks help the panel, right? They are there for you. They shouldn't make your life complicated. They should make your life easier. And they help protect against undue influence. They help you reach consensus by looking at criteria individually. I can tell you that at some point that consensus is always needed, but it can be reached much, much more quickly. And consensus is required whether or not you have good evidence or poor evidence. You cannot make nonsense judgments when you use the ETDs, which often happened in the past. And they particularly allow you to identify when the grade rules for strong recommendations in the face of low or very low quality evidence apply. Thank you very much.